Good afternoon, everybody. We will be starting in 5 minutes.
Siyempre, sinimulan ko na eh. Hi, Sir Paul!
Bye-bye!
Good afternoon, ladies and gentlemen. I am Nico Barzago of UPPSA, taking over as your host and moderator for this afternoon. Earlier today, we talked about health systems and public policy in the context of the pandemic with Doctors Domingo and Berce, after which we discussed the COVID-19 response with Doctors Burba and De Castro. Again, it is quite unfortunate that we won't have Dr. Raul de Stura today as our speaker, but for this afternoon, we will start off with two speakers for the basic and clinical research for COVID-19, and then proceed to a discussion by one speaker about the COVID-19 response, particularly of vaccines. Are you excited? I hope you are. May we remind everyone of our house rules. Please don't forget to mute your microphones. During our open forum sessions, please course your questions through our Slido for me to read to our speakers. Don't forget to indicate the name of the speaker the question is directed to. Our Slido code is 781601. You may also upvote questions that speak your curiosity aloud. Again, the Slido code is 781601. As greatly encouraged, you also have the option to raise your question personally by raising your hand in Zoom for me to acknowledge. Questions through the Zoom chat box may also be directed to the MedEureka Q&A. To start with basic science in COVID-19, our first speaker is the current director of the Institute of Herbal Medicine in the National Institutes of Health. She is currently a professor and is the assistant chair for research at the Department of Pharmacology and Toxicology, and the clinical professor at the Division of Infectious and Tropical Diseases and the Department of Pediatrics at the UP College of Medicine. She currently serves as an advisor to the editorial board of the Journal of the Pediatric Infectious Disease Society of the Philippines and is president of the Philippine Association of Medical Journal Editors. In addition to being a medical doctor, she currently holds a Master of Science degree in clinical trials, as well as in infectious diseases from the University of London. Here to talk to us about the investigation of Lagundi for the treatment of mild COVID, everyone, please join me in warmly welcoming our speaker, Dr. Cecilia Maramba Lazarte.
Good afternoon. Thank you for that very nice introduction. Kalakas ng ilaw ko. Anyway, mamaya ko na ayusin. So thank you for this invitation. I'm very honored to be here and speaking to you. And I'm very impressed with all your activities so far. And I'm so happy that you all have a healthy yearning for research. And we hope to cultivate that more. And I hope this talk will not discourage you, but even open up your eyes to even be more interested in research. So I'll be sharing my screen. Okay, can you see the screen?
Yes, po.
Okay. So, well, you've been talking about COVID since this morning, and this is one of the responses that we wanted to give in trying to help in the treatment of COVID. Okay, so we also looked into repurposing existing products, and this is one of the products we saw some potential. So this is what we will be discussing in the next few minutes. Just look at some modern medicines, which were actually taken from plant sources. The history of Lagundi, its discovery and the clinical researches and non-clinical researches behind it, why we want to use it for COVID, and the conduct of the clinical trial. Now, we were hoping that we would have already finished analyzing the results by now, but unfortunately, I will be explaining in a while, we are not there yet. Okay, so plants, as you know, produce so many types of compounds, And they themselves, as plants, have to protect themselves against pathogens. And some of these compounds which they use against their own pathogens can also actively can be used by humans. I'm sure you are very aware of this cinchona bark, which they used to isolate quinine, no? And it was used for a very long time to treat severe malaria. I'm not sure if you know this, that oseltamivir was actually derived from your Chinese star anise, no? And after several chemical reactions and to get a better compound, they were able to produce oseltamivir. And we know that it is used to treat and prevent influenza A and B. And of course, I'm sure you are aware of the Nobel Prize winning pharmacist Yu Tu, who discovered or isolated your artemisinin for your Artemisia annua. And this is part of the first line treatment that we use in chloroquine resistant Plasmodium falciparum.
Ang National Integrated
Sorry. So,
ang amin po
hindi ko natanggal yung ano. So these were the pioneers of IHM, no? And actually sa kanila galing yung Lagundi. And this whole group started in 1974. You can see very prominent pharmacologists, botanists, chemists, no, here in this group. And they were actually the pioneers, which later became, the NERPROM later became part of the Institute of Herbal Medicine. And their vision was really, and mission was to produce affordable herbal medicines from Philippine medicinal plants so that we could create efficacious, safe medicines that would be able to reach the farthest regions of the Philippines.
ang amin
Okay, so this is what we are doing at the Institute of Herbal Medicine. And this was also started, of course, by the NERPROM. No? We practice what you call mostly traditional medicine-based herbal medicine, and in a way, you could also call it reverse pharmacology, wherein we look at the clinical first. No, we don't start with the receptor or the targets, but we look at what was practiced in the past by our traditional medicine healers and see if we can validate what they were doing. No, we've seen that we have a higher rate of hits in doing this than just doing random screening. So many of the present products which were produced by NERPROMP and the IHM was done in this manner. And it is also the mission of the Institute that we address the diseases which causes the highest morbidity and mortality in the Philippines. So those are the indications that we look for. And we have several units, the agricultural unit, the preclinical unit, the formulation unit, and the clinical unit, which work together so that we could do all the researches to produce these herbal medicines. So what is important here is that we don't work in silos. We work together as a team, so that we could produce the best product. Now, I'm saying this because hindi naman ito exactly straight arrows lang, no? Let's say you do preclinical researches and then you feed what you know to the formulation team, and they will create a formulation which you need. And then you go through the clinical trials, and sometimes you still need not to tweak your formulation. So you go back to the formulation team so that you could tweak this formulation as you go through the clinical trials. So really, the teams should not work in silos. So let's go back to our Lagundi, the The shape may look familiar. This is not marijuana. This is Vitex negundo, also called as your five-leaf chase tree. And the many non-clinical studies done even in the 70s showed that this was a very, very safe product. The acute toxicity was very, very high. So if you look at the LD50 in human equivalent dose, you probably need to take 1,000 tablets for you to get to the LD50. And even the chronic toxicity really did not show any significant symptoms or abnormalities. So in the non-clinical researches, they saw several clinical activities, including bronchodilation, no, antihistamine effect, and anti-inflammatory, and eventual studies with the help of many other researchers, including Dr. Toby Dairit, who helped isolate many of the compounds here, and they correlated the isolation with the pharmacologic activity, no? So importante 'yon na kino-correlate siya with the pharmacologic activity, na not just to isolate the compound. So here he saw compounds which were antihistamine, stabilized mast cells, were bronchodilators. No? So even luteolin, isoorientin were antihistamines. They also saw compounds which were anti-inflammatory, had anti-leukotriene activity and anti-inflammatory activity. No? So many of these are needed for what they later saw in the clinical trials, its usefulness in cough and even in asthma. No? So if you look at how we treat asthma, no? So you would need a reliever, a bronchodilator, and controllers. No, they could be antihistamines, anti-inflammatory, or even anti-leukotriene activity, of which actually are all present in your lagundi. Now, this is just a forest plot of the meta-analysis of the cough syrup for children for cough of non-bacterial origin, just trying to document its bronchodilating effect. So if you look at the last diamond, it was favoring Vitex negundo, looking at the PFR at the end of therapy. And this is the same meta-analysis looking at also the Lagundi syrup for reduction of frequency of cough. The top is the best case scenario, and the lower part is the worst case because there were some missing data. So they put a best case and worst case scenario. In the best case scenario, highly favors Lagundi. In the worst case scenario, still favors Lagundi. Now, why were we actually thinking of that it could possibly help in your COVID-19? No? There was this paper which was an in silico research doing molecular docking analysis of several compounds and see what was its affinity to your to your SARS-CoV-2 RNA-dependent RNA polymerase. And two compounds of Lagundi, your quercetin and vitexin, actually had a very high binding efficacy to this particular target. Oops, there's one more. And another paper showed that vitexin also had a high affinity to 3 virulence factors also of your SARS-CoV-2. So if you look at the constituents of Lagundi, no? So in your patients with COVID-19, they have cough, they have difficulty breathing. At the same time, there's viral replication going on, and there's also inflammation going on, which can worsen the clinical picture for the patient to go into moderate and severe disease. And many of the compounds here would be helpful in one, the symptomatic treatment in terms of the cough and bronchodilation. There are also compounds which are anti-inflammatory and possibly compounds that are also antiviral. No? So the thinking was, where's that? Okay, if you look at these stages of COVID-19, we were thinking that it would be most useful in the viremic phase, which is very early in the infection where there is high viral replication before the inflammation phase or the pulmonary phase. And we could use Lagundi for the symptoms, which are usually cough, fever, okay, and as well as if it were truly antiviral, we could decrease the viremia and hopefully not proceed to the more moderate or severe phases. No? So as of now, kasi a lot of people still use Lagundi but more just for symptomatic treatment of the cough. No? So pwede ba siyang ibigay kahit walang symptoms ng cough but just give it in the very early stage so that we could stop this viremia. So what we used are the licensed technology from the near prompt, which is the 300 milligram and 600 milligram tablet, and the syrup, the 600 milligram per 5 ml syrup. No? So these are registered herbal medicines. They are not supplements. They have an HMR number, and there are several licensees of this technology who has licensed it out from UP Manila. Okay, so these are just examples of the products that we actually used. So it's tablet, not capsule. There's some capsules out there which are not our technology. We found that they had poor dissolution time, and there are some other Lagundi products registered as supplements. Hindi rin yon. Kaiba yung kanilang formulation, and we will not guarantee the efficacy of these products. So the long version of our study was called a two-staged randomized double-blind placebo-controlled clinical trial on the efficacy and safety of Lagundi with standard treatment compared to placebo with standard treatment in patients with mild COVID disease without comorbidities. No? Ano bang standard treatment? No? So quote-unquote supportive therapy, standard treatment is of course monitoring the patient. You can give vitamins, of course hydration, and nutrition is very important. And these are what was allowed during the trial. So the short title of the study is EVIC, Efficacy of Vitex Negundo for COVID-19 Trial. So I said two-stage. What was the first stage? The first stage was a dose-finding study. So this was an adaptive trial. No, the first stage was a randomized open-label dose-finding and safety study. So this was a smaller version of the large trial, and we'll just go through it. So these were our trial sites for stage 1, the Quezon Institute and the Camp Bagong Diwa Special Care Facility in Taguig of the NCRPO, of which we are very grateful to them. And the objectives was to determine ano bang mas magandang dose, yung high dose, the 1.2 grams TID, or the usual dose, which was 600 milligrams, TID. No? So we would look at efficacy as well as safety in patients with mild COVID-19 without comorbidities. Okay, so these were the specific objectives, and they actually outline what our outcome measures are. No? So in terms of efficacy, we were looking at the mean clinical recovery time, time of resolution of influenza-like symptoms like cough, sore throat, body malaise, fatigue, feverishness, percentage of patients with improved symptoms based on the global evaluation scale for both the patients and for physicians. So we also want to see if in any of the doses, would they progress to moderate or severe disease? and to document the adverse effects of, if any, for standard dose and high dose. Okay, so this was already mentioned, the high dose and the low dose. Wait, this thing is in the way. This is just an algorithm showing the dose finding. Of course, we get an informed consent and then randomize them to the two groups. And these are the endpoints on the bottom, and we follow them up every 3 days until day 20. And we finished stage 1. We screened 295 patients, of which 220 were excluded. Many of them did not meet the inclusion criteria, were either asymptomatic, wrong age group, had comorbidities, or even refused to enter the study. And 75 were randomized, 39 to the high dose, 36 to the normal dose. We had very good follow-up because they were all staying in the quarantine centers and all were available for analysis. So for stage 1, the Lagundi tablet and syrup were well tolerated in both high dose and low dose, and not low dose, normal dose in the majority of the patients, and none of the patients progressed to moderate or severe. Now, if you look here, no, at the mean clinical recovery time, halos pareho lang, no, the high dose and the normal dose, that shouldn't be low dose. Group A here is the high dose and Group B is the normal dose, and there was no statistically significant difference in terms of the global scales and percentage improvement. Okay. And for adverse events, halos pareho rin lang. We saw diarrhea, pruritus, no nausea or vomiting seen. We already have seen diarrhea and pruritus previously in clinical trials, but these also were only mild. Okay, and by and large, it was well tolerated. Okay, so marami kaming problems dun sa first stage. Many patients come in very late before they get to the quarantine center. Many patients are on unnecessary antibiotics and enrollment is very, very unpredictable. Sometimes ang dami-dami kung may surge, minsan halos wala kung walang masyadong infections. Okay, so this is the second stage. So this is the larger trial, no? It's a randomized, double-blind, placebo-controlled clinical trial. So we used the normal dose here because halos pareho lang sila sa high dose and compared it to placebo plus standard of care in patients with mild COVID disease without comorbidities. Actually, the outcome measures are very similar as that of the dose finding stage 1, no? If you look at number 1. But what we did differently here is that we did serial RT-PCR for SARS-CoV-2 in half of the patients so that we could, syempre this is very expensive, we could not do for everybody, hindi kasya yung budget namin. But we did at least for 100 patients. Did serial RT-PCR so we could see mas maaga ba nag-negative, or they also gave us CT values or CQ values, and we would try to see if there is a decrease in the viral load. Okay, so again, the arms, this time, the dose that we chose for 100 patients plus standard of care versus placebo plus standard of care. No? So yung placebo, yung makikita mo yung really the natural course of disease if they are just given standard of care. Okay, so a similar algorithm. What is different here is the addition of the serial RT-PCRs that we got from our patient every 3 days. Okay, and actually ongoing pa ang stage 2. We're completing the last few patients. Hopefully we are finishing enrollment. Not we finished enrollment, but we're just following up the last few patients till next week. Okay? So we actually screened 1,056 patients, but out of them only enrolled 203. For 2A, 2A is those where you do serial RT-PCRs, and 2B is without the RT-PCR, but we will of course still put together all the clinical findings together. The actual computed sample size is 186. No? So we had a few withdrawals, and I think we will still reach our 186. So this is what I have put together for the consort diagram so far. No, we have not been unblinded yet. So hindi ko pa mabibigay yung analysis, but we assessed for screening 1,056 subjects, excluded more than 800 because they did not meet the criteria or declined, randomized 203. Some were allocated if they agreed to having serial nasopharyngeal specimens every 3 days to 2A, and those others to 2B, those without serial RT-PCR. Those who had serial RT-PCR were again randomized to either Lagundi plus standard of care or placebo plus standard of care. And the same was done with those without serial RT-PCR to receive half received Lagundi plus standard of care and the other placebo plus standard of care. And of course, in the analysis, we will put together all those with Lagundi and all those with placebo. So we had to go to more quarantine sites to really try to hit our target. From QI, we got 23. From the most are actually our uniformed police, no, 127 from all over NCR. From Valenzuela City, we had 26 patients. From Pasig, 24. From UP Diliman, 2. From Manila, 12. And just lately, because of the big surge, there was an extension for mild COVID in PGH, especially for the employees. We got 6 patients from there. So as I said, we are still following up the last few patients until next week. Data is still blinded, but happy to say there were no mortalities. None of the patients went into ARDS. None of the patients progressed to severe. All patients recovered and were sent home. We still have to analyze the time to clinical recovery, time to negative RT-PCR, or decrease in viral load using the CT values, time to resolution of COVID symptoms, and improvement based on patient and physician scale. Just to take a quick look at the adverse events, although we still have to analyze their causality because some of the adverse events here are actually also symptoms of your COVID, no, like diarrhea. So these are the events reported. They mostly were mild. So by and large, it was well tolerated also. So we still have, these are the last few slides which are actually just pictures of us at the area. No, the first one was in QI, that's our headquarters, but you go outside to the facility. This was in PNP, nasa ilalim ng araw in complete PPE. Halos nahilo-hilo na kami doon. This was in Rizal High School. This is Silungan Molave, and this is Valenzuela City. I'm sure you recognize what this looks like. These are our labs in Pas Mondosa where some of our mild were hosted for a while. Na-disinfect na yan. So okay na yan. And this is our team who worked so hard in trying to getting all these information. We used ECRFs. We had a tablet which we brought in so that we don't have to bring papers home which may be contaminated. So running a clinical trial is definitely not an easy task, but it was very fulfilling. Setting it up was not easy. Writing protocols, getting approvals and funding, and networking for the trial sites took a lot of work. It was physically and mentally demanding. Imagine yourselves in full PPE under the sun. I almost passed out once. There is very unpredictable enrollment, which was why we had to add more trial sites. Many patients come very late into the illness, so sometimes they're already asymptomatic, and we had to exclude these patients. The risk of contracting COVID for the study personnel carries additional risk mitigation, expense, and mental burden. No? So pag may nagkakasakit sa team namin, parang talagang nakakapraning minsan. But we are very grateful to donors and friends who helped us along the way. We will still do the analysis, and it doesn't look to be easy either. These were our sponsors, the PCHRD, DOST, the IHM itself also invested in these trials. We had donors who gave us PPEs, who gave us the drug and the placebo itself, and some anonymous donors who gave PPEs who did not want to be announced. So thank you very much for listening to this, to my presentation. And we hope to give you answers soon. We promise to be truthful and transparent in giving what the results will be of this clinical trial. Thank you very much.
Thank you very much also, Dr. Maramba Lazarte, for giving us that panoramic view of the role of Lagundi in the treatment of COVID-19. Truly, I believe that this initiative shows us the innovative spirit of a treatment regimen designed by Filipinos for the Filipino people. And that precisely, I think, is that glimmer of hope that we all need at this point in time. Now, our next speaker is a diplomate in adult hematology and transfusion medicine and is an active consultant at both the Philippine General Hospital and the San Juan de Dios Educational Foundation Incorporated Hospital. In light of the pandemic, he currently serves as part of both the technical working group of the UP PGH Convalescent Therapy Program and the technical advisory group of the Department of Health Convalescent Plasma Program. In addition to numerous awards and honors, he has also received advanced clinical training in hematology, particularly in immune-mediated hematologic disorders, eosinophilia, and histiocytic disorders from the University of British Columbia and Vancouver General Hospital. Here to talk to us about convalescent plasma therapy and COVID, let us all welcome our second speaker this afternoon, Dr. Dion Thaddeus Gawira.
Hi, good day, everyone. Thank you very much, Nico, for that very kind introduction. Let me just pull out my slides. Thank you again to the UPPSA for the invitation to share some insights regarding convalescent plasma therapy as a therapeutic option for COVID-19. So I have no disclosures, and in this presentation, I would like to discuss the mechanism of action of convalescent plasma therapy, or CPT for short, its risk and benefits, to present how we did the program here in the Philippines, our local experience, and specifically its compassionate use and the institutional RCT that we are also doing right now. And we also like to give an update regarding the latest findings and recommendations on its use for COVID-19 from local societies and even international societies. So let's start off with the mechanisms of action of convalescent plasma therapy. So convalescent plasma is actually plasma that you take from a person who was recovered from an infection. In our case, it's COVID-19. So this plasma contains neutralizing antibodies against COVID-19, and this one gets transfused to another patient who is currently afflicted with COVID-19 as a form of a passive antibody therapy. And this is a form of passive immunization, which will deliver short-term immunization to the recipient by providing your specific COVID-19 antibodies. COVID-19 convalescent plasma, or CP, can also be called immune plasma. It's also called hyperimmune plasma. So basically, it's more or less like your fresh frozen plasma or plasma frozen within 24 hours or PF24. But the only difference is really you are obtaining this plasma from donors who have already recovered from COVID-19. So this is not an FDA-approved product. It's an investigational agent. It's not very much available in all institutions. In fact, there are only, I think, less than 20 institutions in the whole Philippines who has been accredited by the DOH National Voluntary Blood Services Program to be collecting sites for our convalescent plasma. So this is a picture of an example of convalescent plasma therapy unit. So it's colored yellow to orange. So and it's pretty much looks like your typical fresh frozen plasma. Convalescent plasma is obtained from patients who have already recovered from an illness. So when we were starting out the program, we had to identify who are the best donors to become, who are the best donors of the convalescent plasma. So we were actually under the guidance of different experts from one primarily was Professor Arturo Casadeval of the Johns Hopkins, and they have their own convalescent plasma program in the United States. You also have friends from Singapore and other Asian countries, the WHO, and even the International Society for Blood Transfusion. So they help us craft our own convalescent plasma program here in the Philippines. So when we were starting, our first priority, we want donors who were previously diagnosed with COVID by RT-PCR. It has to be confirmed, and they have to have recovered from COVID as exemplified by a negative RT-PCR on recovery, and they should be at least asymptomatic for 14 days before we allow them to become donors. Then eventually we placed second priority and third priority as we were already having a lot of changes in the way that we were managing COVID-19. Some of our patients who had COVID-19, from the start, we were using the RT-PCR to say that they have recovered, but eventually the DOH had a guideline that we were already using the time-based approach to saying that they are already recovered. That means if they are already within 14 days of illness and they are asymptomatic, they will already be tagged as recovered, and you don't need to repeat your RT-PCR to say that they have recovered. So the second priority will take care of that. But these patients, initially, they have to be asymptomatic already for 28 days. But eventually, we had to lower it down to 14 days because we were fearing that we might be missing out on the potential donors if we will be extending it too much to 28 days. But the DOH guideline still says that it's 28 days. And finally, we have those donors who were never really diagnosed formally with an RT-PCR, but they had themselves tested for antibodies, and these were eventually turned out to be positive. So they were also allowed to become donors as long as they are asymptomatic for at least 14 days. Basically, how we select our donors is also very much similar to how our DOH and VBSP chooses the regular blood donors for your packed red cells and your platelets and your fresh frozen plasma. So they must have passed the standard DOH blood donor history questionnaires so that we can weed out those with possible comorbidities, which will be harmful for these donors if we get a significant amount of blood from them, and so that we may also decrease the risk of transfusion transmissible infections. Donors should have at least 50 kilograms. They could be of any gender, but we're quite strict in terms of this. If you have a donor who had a prior history of blood transfusion, or a female donor with a prior history of blood transfusion and or previous pregnancy, we had to have them tested for anti-HLA antibodies, because these donors, when you get plasma from them, there is high risk of the recipients of the plasma of having your TRALI or your transfusion-associated lung injury. And that's one significant cause of morbidity and mortality among those who receive plasma therapy or any type of blood transfusion. So we have to mitigate that risk by eliminating these potential sources of the anti-HLA antibodies. And these donors, they should have acceptable laboratory parameters like hemoglobin of more than 12.5 for females or 13 for males. They should have normal platelet counts. And when we first started, we really didn't have the tools of getting antibody titers. So ideally talaga, when we do convalescent plasma therapy, these plasma units should have the neutralizing antibody titers through your PRNT testing. Unfortunately, this is not very much available in the whole country. But fortunately, we have some guidance from the other institutions and even the US FDA. They did some analysis, and they found out that the neutralizing antibody assays actually correlate with your endpoint anti-SARS-CoV IgG. So now we're using the IgG as a surrogate for that neutralizing antibody titer. And we're using semi-quantitative means right now. So we have in PGH our chemiluminescent assays to check for IgG. So it's now semi-quantitative, as we have been using a signal to cutoff ratio of at least 9.5 to say that our units have a significant amount of antibody titers. They should have negative antibody screen, and of course, we still do the regular panel to rule out transfusion transmissible infections like hepatitis and HIV. So we obtain plasma through two processes. First is the usual whole blood donation. I think you're more familiar with this one, but we have already increased usage of apheresis. So apheresis, this is a better technology, albeit a more expensive technology, because in apheresis, we take out the whole, the blood of the patient flows through a high caliber IV access, and this goes through a machine, and through centrifugation, we are able to separate the plasma from the red cells and the platelets. So we are able to take out the plasma, but return the platelets and the red blood cells. So this is more convenient because we're able to get higher volumes of plasma. The patients won't be anemic or thrombocytopenic because we will be returning their platelets and their red blood cells anyway. And when you do apheresis collection, you can actually have donors donate every 2 weeks, as opposed to your whole blood donation, which takes out pretty much whole blood. So it includes your red blood cells and your platelets. So each bag can only give 1 unit of convalescent plasma. And the length of time before they can donate again would be 8 weeks. So the yield for whole blood donation is actually lower when you compare it with apheresis. So we prefer to do apheresis. But the DOH NVBSP ruling is that for most patients, we start off first with whole blood donation. But if they have consent, we can do the apheresis. So convalescent plasma contains neutralizing antibodies, anti-inflammatory cytokines, clotting factors, natural antibodies, defensins, pentraxins, and even other undefined proteins. And the main mechanism by which CPT helps in COVID-19 is primarily by viral neutralization. So in SARS-CoV and MERS, the neutralizing antibodies bind to the spike 1 receptor binding protein, S1 N-terminal domain, and the S2. Thus, you limit the entry of the virus, and you also limit its amplification. So the FV region of the immunoglobulin typically mediates this viral neutralization. There's also antibody-dependent cellular cytotoxicity and phagocytosis. And as mentioned earlier, there are other protective antibodies in the convalescent plasma. These are the non-neutralizing antibodies, which also bind the virus but do not affect its capacity to replicate. And these are thought to help in COVID-19 by also affecting immunomodulation. So it's almost similar with your intravenous immunoglobulin administration, where CPT also provides immunomodulation by neutralization of your cytokines, neutralization of your complement, and even your autoantibodies. And these effects are mediated by the FAB region of your immunoglobulins. And finally, your convalescent plasma may also modulate the immune responses via the Fc gamma receptors. And in addition, it may also enhance the anti-inflammatory properties of your dendritic cells, T cells, and B cells. So interestingly, this is only a very recent publication which tried to investigate the mechanisms of CPT by comparing the composition of your plasma from healthy people pre-pandemic, those who are hospitalized with COVID-19 and had severe disease, and those who have already recovered from a COVID infection and became donors of your convalescent plasma therapy. And in this study, we found out that when you give your convalescent plasma therapy early, that means within 14 days of disease onset in those with severe disease, you actually decrease your interleukin 6 and over your interleukin 10 ratio. So interleukin 6 is a pro-inflammatory cytokine, and IL-10 is an anti-inflammatory. So higher ratios of IL-6 over IL-10 is associated with higher disease severity and higher morbidity. And so CPT helps by lowering down your IL-6 and improving your IL-10. It is also able to decrease your interleukin 6 to interferon gamma ratios. So interferon gamma is important for viral neutralization. So this study also showed that there's immunomodulation by improving the interferon 10 and decreasing IL-6. There's note of early but transient increase in your TNF alpha, interleukin 8, interleukin 17A, your granulocyte macrophage colony stimulating factors, and interferon gamma, which are really helpful in your viral clearance. So basically, convalescent plasma really has multiple plausible mechanisms of action, but we really don't know, apart from the main fact that we use it for viral neutralization, what are the other means that CPT can help patients. But knowing that CPT helps primarily by viral neutralization, so similar to other drugs, we want to give it early because we want to neutralize the virus. Later on, when there is already end organ damage, we really don't see how CPT will be able to affect the patient or how it can lead to improvement, apart from still some immunomodulation. But really, for it to become really useful, you have to give it early. And so we tend to give it earlier, less than 14 days. So CPT is convalescent plasma therapy really as a form of passive antibody therapy is not a new therapeutic modality. In as early as the 1890s, Behring and Kitasato have started using passive antibody therapy for treatment of diphtheria and tetanus, with Behring eventually receiving the Nobel Prize in 1901 for this work. Afterwards, passive antibody therapy was increasingly being used for other illnesses. And in the 1930s, it took a step back with the development of effective antibiotics, such as your sulfonamide and your penicillin. And in the interim, we have been using it for a lot of other illnesses, infections. In 2003, CPT was again revived and it's used for SARS-CoV. And in 2009 for the H1N1 and the influenza virus pandemic. It was also used in the 2012 MERS-CoV epidemic and the Ebola outbreak from 2014 to 2016. So looking at it, really CPT is a bridge until we get that drug, that antiviral drug or drugs which will really be very useful for the infection itself. It will serve as a bridge. No? And that's how it was really used in the past. In terms of the potential benefits, so when the pandemic hit in early last year, so we were seeing a lot of papers from China. They were using convalescent plasma therapy, and their initial case reports showed that there is reduction in their viral load after 3 days of giving CPT. There's reduction in inflammatory markers. there's decreased respiratory demand, and there's radiologic improvement. And this is what they use as a basis for saying that these patients who received CPT had improved survival. Looking at its safety profile, so basically, as I've told you a while ago, it's pretty much the same as your typical regular plasma donation. Regular plasma transfusion, and it carries the same transfusion-related risks as follows. Although there are reports of detection of your viral SARS-CoV-2 RNA in plasma samples from blood donors, further investigation of these donors failed to confirm the presence of the variants in the blood. So right now, we really don't have direct evidence yet that the virus could be transmitted in blood products. So we don't need to do pathogen inactivation for donors with COVID infection because your red blood cells do not contain the ACE2 receptors. And modeling studies have shown really that the risk of transmitting your SARS-CoV-2 via blood transfusion is really, really low. But I'd like to give an emphasis again on TRALI. We've mentioned this a while ago in terms of reducing its risk by eliminating donors who have been previous recipients of blood transfusion and those who have prior pregnancy. Because when you give CPT for patients who already have very severe pulmonary disease, it's really hard to say if these patients get dyspneic with transfusion, if they have worsening COVID, or if their reaction is TRALI, because they can pretty much present similarly, and TRALI can happen within 6 hours of blood transfusion. So that's why we tend to avoid using CPT for those who have severe pulmonary disease, because it's really hard to know which is which. One potential theoretical CPT risk, this was also showed also a concern with the vaccines early during the pandemic. It's antibody-mediated enhancement of infection, or ADE. So it's a reaction which can occur with other viral infections like dengue, yellow fever. And it may occur through two distinct mechanisms. First is there might be enhanced antibody-mediated virus uptake via the Fc gamma receptor 2A expressing phagocytic cells. And this will lead to increased viral infection and replication because they can evade the immune system. And second, there might be excessive antibody Fc-mediated effector functions or immune complex formations causing enhanced inflammation and immunopathology. So these pathways can occur when you have non-neutralizing antibodies or antibodies at sub-neutralizing levels, and they bind to viral antigens without blocking or clearing the infection. This also emphasizes the need to have significant amounts of neutralizing titers in your convalescent plasma therapy. But so far, with the experience that the other countries have been showing, there was no report yet of ADE with convalescent plasma therapy. Another theoretical risk is that with experience with mice, they're saying that giving CPT might attenuate the response of patients to the infection, and they might be vulnerable to subsequent reinfection because passively acquired antibodies may suppress the humoral but not the cell-mediated immunity. This is also a theoretical concern at this point, and we don't have actual evidence of it. So basically, with our data, we saw that this is generally well tolerated and pretty much same as your standard plasma. Data from the expanded access program of US showed that in 22,000 patients, they only had transfusion reactions in less than 1%. The reported thromboembolic complications and cardiac events in less than 1% to about 3%, but most of these were judged to be not related to convalescent plasma therapy. When they checked the overall mortality at 7 days, it was 8.6%. It was lower than the earlier reported mortality rates of 12%. So it's generally safe. So in terms of our local experiences, so I told you a while ago, we had help from ISBT, the WHO. So we've crafted our own guide in the compassionate use for CPT, and this was included in the ISBT repository for access of other countries so that they may also create their own programs. So this is our guide, and we have been constantly revising it in the past. Through the help of UPPGH and a lot of our friends from pathology, from blood banking, we had a call for convalescent plasma donors, and it's still ongoing. So we had information materials, and we use social media. social media to ask for donors. We had partners from all over the country who are also helping us with this. So those who had severe disease or life-threatening disease are the first patients who were able to receive CPT in UPPGH through its compassionate use. So because this is what the US FDA was also recommending earlier on during the pandemic. So it's usually combined with other disease-specific and supportive care interventions. It's an attempt to improve the clinical course of patients in those already ill, but it should not be delayed while waiting for benefit from other treatments. So we usually give two type-specific units, so about 250 cc's each. We thaw it and we transfuse it over 2 to 3 hours. And we monitor them similarly with those who receive blood transfusions. And the response assessment is basically how we also monitor the response of all patients with COVID-19. And we have been doing it in compliance with FDA. We've been reporting weekly our outcomes for CPT recipients, and we also report serious adverse events to FDA using their VigiFlow management system. So for the past year, we have been able to give it to 108 patients, median age of 6 years old, males in 63%, and we have been able to give it within 12.5 days. Most of these patients also has metabolic diseases like hypertension, diabetes. Most of them really receive steroids because steroids became one of the backbones for treatment in our COVID patients. 30% had one co-intervention, which is likely steroids. So 51 had severe disease and 57 with life-threatening disease. And this is just the crude data. We're still doing a match control study with our crude data. So as you can see, most patients with severe disease who received CPT were discharged, but those who had life-threatening disease eventually expired. The overall discharge rate was 58.3%, 40.7% expired. We only had 4 adverse events, and majority of these are judged to be progressive COVID-19 rather than TRALI. And we just these are just the crude data, but we juxtapose it with our data in PGH, our first 1,500 patients, and you can see the mortality in those with severe disease is a little bit lower than the overall mortality among those with severe disease. The mortality of those who received CPT in those who had life-threatening disease were almost similar to those who had life-threatening disease. So overall, it was generally well tolerated, and our data showed that it was comparable to the reports of the other institutions that you have to give it in those with severe disease, but avoid in life-threatening disease because there's pretty much no more benefit for those who are intubated already. So with that, we're able to give compassionate use, but we also had our own institutional clinical trial, the Co-Clarity clinical trial, and this has effectively expanded the access to CPT in UPPGH by also including those with moderate disease. So our trial is named Co-Clarity trial. It's a randomized, non-placebo-controlled, open-label, single-center clinical trial to assess the efficacy and safety of convalescent plasma given in 2 consecutive aliquots to those who are hospitalized as an adjunctive therapy to reduce the need for ICU admission. So the question that we wanted to answer is that when you give it within 14 days of illness, can we reduce the risk of ICU admission? So we hope to enroll a total of 136 patients, adult patients with confirmed RT-PCR and those with consent. They will be randomized to receive the intervention, 1 dose of CP with SEO of at least 5.0 and standard of care. They will be followed up for a total of 60 days, and we will be assessing their admission to the ICU within the first 28 days of enrollment. And our primary safety endpoint is a rapid deterioration within 4 hours of transfusion of CP and incidence of serious adverse events. For our secondary endpoints, we have been monitoring their SOFA scores, if they go into CP arrest, ICU admission, mortalities, lengths of stay, and organ support 3 days like ventilator support, dialysis, vasopressor, and need for ICU care. And we have also been comparing their anti-SARS-CoV-2 IgG levels and SARS-CoV-2 RNA levels, the CT values of using RT-PCR at various time points. So adult patients who had consent and if they agree to storage of specimen, they will be excluded if they are pregnant, if their illness is more than 14 days already, And if on clinical presentation at the hospital, they're ready for ICU admission because this is our primary endpoint. They should not have received any blood product for the past month. They should not have IgA deficiency because IgA deficiency increases the risk of anaphylaxis after blood transfusion, and they should not have any other contraindications to blood transfusion. So that study is still ongoing, and we're almost reaching our first year mark. Unfortunately, we have a problem really. It's hard to do clinical trials because the patient population in PGH is very labile. We wanted to include those with moderate disease, but there were times when all the admissions had severe disease, like what we're doing right now. And there are also a lot of other ongoing clinical trials in PGH. So some of the participants, when they consent to one study, they don't like to consent to another study already. So we're working with a limited number of participants. But looking at the latest data, so there are a lot of clinical trials on CPT. In clinicaltrials.gov, there are at least 130. But through the Philippine COVID-19 Living Recommendations, this is a project of the Institute of Clinical Epidemiology of the NIH, UP Manila, and the PISMID. We already have results of 13 published RCTs, so a total of 13,000 patients from different countries. And just to show you the forest plot. So in this forest plot, we have this line of null effect. So it's placed in the value like 1, where if in this line, there is no difference between the two interventions. So in this case, the experimental group is convalescent plasma therapy, and the control is either placebo or a standard of care. So each study that we include in the meta-analysis will be one line. So when you see the small figure, the box in the middle, that will be the point estimate for the study, and the whole line will be the confidence interval. So as much as possible, we want the line to be shorter. And if you have more participants like this study by Hornby, this is the recovery trial. So the largest box, because they contributed the most number of patients, about 10,000 patients. So you can see the box is larger. And then the diamond is the meta-analysis or the combination of all these. So this will estimate the effect of CPT versus SOC or placebo. So, but we want the diamond to not straddle the line of null effect. So in this pooled estimate, you will see that because there's a trend towards benefit, towards favoring the CPT, but it's not statistically significant because it still crossed the line of null effect. So the pooled estimate in terms of all-cause mortality, if CPT will be able to reduce all-cause mortality, there's really no statistical significance in between using CPT versus comparing it with your standard of care and your placebo. And when the reviewing team headed by Dr. Burag and Dr. Lapitan, they stratified those with different severities because we know that there's really no very limited benefit for those with critical and severe disease from the other trials. But we can see this is the diamond is very wide because it's only one study. So across all severities, all the diamonds were straddling the line of null effect. So again, subgroup analysis based on severity did not show statistically significant difference in terms of the all-cause mortality when you give CPT versus standard of care and the placebo. Also, in terms of clinical improvement at day 28, pretty much the same results, no statistically significant benefit. And even in viral conversion after 7 days, so there's no statistical benefit. So with these, the Philippine COVID-19 Living Recommendations came up with the recommendation last March to recommend against the use of convalescent plasma for the treatment of COVID-19 infection because of the previously mentioned results. And this is pretty much reflected by our international guidance as well. Like IDSA recommends limiting its use only to your clinical trials. And again, they're emphasizing the need to give it higher titer levels. So just a few more slides. So NIH, on the other hand, also recommends against using low titers. They recommend using it for those who are already mechanically ventilated. But there is insufficient data to support its use for those who are not hospitalized. This one is a research gap at this point in time, whether CPT will be helpful for those with impaired humoral immunity, like those who had malignancies, and those who receive anti-CD20 drugs like rituximab. There are a small case report showing some benefit, but we don't have large clinical trials to say whether CPT will really be of benefit for this patient. So this remains to be a research gap for CPT. So what's next? So because of these data and the recommendations, the use of CPT for compassionate use is now discouraged, and we have halted its use in PGH starting April 1. But we are still continuing our local clinical trials. We hope to still finish our clinical trial, and we will await the results of other ongoing clinical trials. We still have a lot, 130 trials, and we will update the local guidance on use of CPT as the information evolve. So what we have learned from our experience is that evidence is really evolving, and we must learn to adapt to change. Because in the start, really, when everyone was running around trying to look for something which can help our COVID-19 patients. Really wanted to give the best for our patients, but now that we have data showing that there is really lukewarm response to CPT, we should be accepting that and do not give it na kasi we have data that really doesn't show significant mortality benefits. But what's good with it is we knew that we have the capacity to create a system which will be of benefit if ever we, again, are faced with an emerging infection. We now know how to mobilize donors. We now know how to get convalescent plasma therapy, how to bank it, how to give it to patients. So I think that will benefit us in the future. And this, our experience in PGH was also help us also helping the DOH in coming up with their other recommendations as well. So in summary, convalescent plasma has multiple plausible mechanisms like bilateralization and immunomodulation. Its safety profile is generally well tolerated, but the RCTs have failed to show significant improvements in mortality, clinical improvement, when you compare it with standard of care and placebo. So this has led our expert panels to recommend against its use, except in the context of a clinical trial. So again, with that, thank you very much to the organizers of MedEureka for inviting me over. And I'd like to thank all the members of the UPPGH Convalescent Plasma Therapy Technical Working Group, the different departments, the divisions, the USTPCHRD for helping us with our study and funding our study, WHO, and even ISBT, and all these people who all made this possible. So thank you very much.
Yes, thank you very much, Dr. Guren, for that insightful and informative talk. And it is reassuring to know that we are not lagging behind. At least the Philippines is not lagging behind in exploring multiple modalities for the treatment of COVID-19. Because with all the current focus on vaccines and prevention, it's good to once in a while shift the lens to treatment or therapeutics. Now, at this point, we will have a 20-minute open forum for the previous talks of Dr. Marambela and Dr. Gawir. Again, you may enter your questions through Slido. Go to slido.com and enter the code shown on your screens and in the Zoom chat. Don't forget to indicate the speaker it is directed to. If you would like to speak, please use the raise hand function in Zoom and wait to be acknowledged before unmuting yourself. Kindly introduce yourself before giving your question. If possible, please turn your cameras on when speaking. Yes, can we call Dr. Salvador Cohili? He has a question.
Hello, thank you. Can you hear me?
Yes, sir.
Okay, thank you.
Badong.
So, hi, hello, yes. My question is, I suppose directed to Dr. Gawiran mainly or exclusively. So, given that it's been challenging to demonstrate clear benefit for convalescent plasma, do you think the situation might be different if the antibodies from these donors were to be separated or concentrated and used as a distinct therapeutic product? So sort of like with more processing of the plasma to enrich the antibodies and probably to identify if the antibodies, the antibodies as neutralizing in particular. Is there any like move in that kind of direction, do you think? Thank you.
Thank you, Sir Badong, for that question. That's the use of hyperimmune globulin, where they concentrate the convalescent plasma products. Other countries have started doing this. There are small reports of them doing it, and it's really it will be able to reduce some of the side effects of convalescent plasma therapy, like pulmonary congestion because of the large volume of CPT that we are using. So if you are able to concentrate those neutralizing antibodies into a smaller amounts, and that would be really of benefit for our patient. But the challenge why we cannot translate it here in the Philippines, because first we have a limited donor pool. So one donor can only give so much. And so we don't have that capacity to concentrate that. And I'm not really sure if we also have. I didn't talk with other people, but I think we have the capacity. But we in PGH we haven't discussed doing the concentration to do it as a hyperimmune globulin product. But there are also some guidance regarding hyperimmune globulin products.
Yes. Actually, I think in a way, moving forward, although we might have problems getting antibodies from COVID patients or recovered COVID patients, the fact that we have this vaccine rollout, this massive vaccine rollout, provides yet another possible cohort of donors who were, and if it goes into the millions, then maybe we can look at this possibility as well of like having vaccinees become donors for plasma to make hyperimmune globulin. Thank you.
Yes, sir. In along that line, sir, actually, we were asking help from the NVBSP if we are able to get these vaccinees as donors, because we know we have some people who have been testing their IgG levels after vaccination, and they have a significant signal to cutoff ratios that will allow them to become donors. But the current guidance really says that those who have received vaccines, COVID-19 vaccines, will only be allowed to donate if they had prior COVID, because of the issue if they are able really to mount a significant amount of antibody. So as of now, the US FDA, the American Association of Blood Banks, and even the DOH and BBSP sticks to that ruling that for vaccinee to be able to become a donor, they must have had prior history of COVID-19 infection.
Okay, thank you.
Right. Thank you, Dr. Kawili, and thank you, Dr. Gawiran, for that response. I'd like to take this opportunity also to acknowledge Dr. Kawili, who is also an advisor of the UPPSA. Now, our next question is for Dr. Maramba Lazarte. The question is from Slido. What is the cause of the side effects of diarrhea and pruritus in patients treated with Lagundi during the first stage?
Well, different people react differently, not to medicines. It could be an allergic reaction. It could be to the Lagundi itself or the excipients. No, kasi alam naman natin in a drug, it's not just the active ingredient. It could be some of the other things you put in to make a tablet, or things you put in to make the syrup. No, so we don't know the exact mechanism, possibly an allergy, but we also have to look more closely into the causality assessment. No, we haven't gone through all of that yet. Kung talagang dahil dun sa Lagundi. Although these adverse effects were also reported in the past, no, in previous clinical trials, but they mostly are very mild, and a lot of people continue the drug and they diminish also, no.
Okay, thank you very much, Doc. And I have another question from Slido. This one is for Dr. Gawiran. Doc, is convalescent plasma therapy affected by the strain of COVID-19 that patients are affected with?
That's a very interesting question. No? there are already some reports showing that because when we first started using it, we're just dealing with the usual wild type of COVID-19, SARS-CoV-2. But we have limited data as to its use for those with the UK variant, the South African variant. But there are reports already showing that it had limited benefits for those who had the South African variant infection. So I think we still are awaiting additional reports regarding its use for the various variants. But we only have like that small data that's saying it's probably going to be less effective for the newer variants when compared to the first variant that we for the wild type that we had.
Right. Thank you for that, Doc. And another question po for Dr. Maramba Lazarte. Aside from Lagundi for mild COVID cases, are there other herbal medicine preparations being studied for moderate or severe cases?
At the moment, wala. I think we have to look also at the limitations of herbal medicines because many of the compounds are at very small amounts, and maybe for a certain compound to be used for more severe diseases, you might need much higher concentrations, no? So at the moment, we are not testing any of them for these indications. But in some countries, they have used some other herbal medicine, although I think for mild pa rin, like in Thailand, they allowed the use of Angiographis paniculata, but not as an antiviral. I think it's more as an anti-inflammatory agent so that you won't go into the hyperinflammation state. No? So other countries are also trying to look into their own indigenous herbals.
Thank you po, Dr. Maramba. For Dr. Gawiran, would patients who are immunocompromised have problems if treated with convalescent plasma for COVID-19?
So the main idea before that they thought that CPT will be of benefit for those who had those who are immunocompromised, specifically those with impaired humoral immunities. That's because since these patients are not able to mount their own immune response, so the CPT will be able to cover for that. So that's one of the things that they're considering, and one of the research gaps that we're having right now. But there are also some of the experts are saying that there might be a problem if we give them convalescent plasma therapy because their immune system is already impaired. When you give them CPT, you might encourage formation of new variants or causing more resistance with that since they are not able to mount their immune response. So there's still much controversy regarding how they will affect these patients who had impaired humoral immunity. But we don't have RCTs yet for this, but we have trials. Case control studies. Those who received rituximab, those who had CLL, chronic lymphocytic leukemia, and the results seem to be encouraging. That means that they are able to clear the virus after a long time. But again, that's fear that we might be encouraging formation of new variants or resistance because we are giving exogenous antibodies for these patients who are not able to process their antibodies well.
Okay po, thank you po, Doc. The question for Dr. Maramba Lazarte. Considering the prejudice against herbal medicine, if ever Langundi is proven to be effective, what is the plan in rolling it out to the public?
If it is effective, syempre we cannot claim it is already because hindi pa namin nakikita lahat ng data. I think the best thing is to show the data to those who are making the guidelines and doing the clinical pathways for the treatment of treatment of COVID. And if the data passes and they think it is good enough to put in the guidelines, then this would be a good way of rolling it out, no? So, syempre kailangan may basbas din ng people in the know and those who would be using it and recommending it also.
Okay, thank you po, Doc. For Dr. Gawiran, says there are studies abroad saying that convalescent plasma is ineffective against COVID-19. And the question is that are these studies also valid here in the Philippines?
One big important difference is between the trials regarding convalescent plasma therapy. Being CPT in itself, because it's really hard to standardize. So when we talk about CPT, we don't know if the CPT here, the titers that we're using in this specific countries is the same as as the titers that other countries are using. So that's one major cause of heterogeneity in the data that we're having. But that also emphasizes the need to have a standard measure of how we get the titers. No, so that's one thing. And again, also there are different trials on different trials that are geared towards those with moderate disease, those with severe disease, or those with critical disease. But mostly, when you look into these trials and select those who have critical disease and severe disease, the data really shows that there's really no benefit. But when you look at the data for those with moderate disease or mild disease, dun mo na makikita na there are some studies who are showing that the risk of them having ICU admission is really low. Some of them showing early clinical improvement, but that's not very uniform then with other countries. There, like we have one in Argentina who showed really good results. We have one study in India who also used the same population, mild to moderate disease, but their results were not very good. One difference really with these two studies is that in the India trial, they did not measure their antibody titers from the start, and they just did it afterwards. And they found out that the titer levels are really lower when you compare it those who received the CPT in the Argentina group. So it's the heterogeneity in how these trials were made, which explains why we have different outcomes then, I think.
Okay. Thank you, Doc. For Dr. Maramba Lazarte, are there parallel studies abroad regarding the effect of Lagundi or any other herbal medicine against mild COVID?
Not I know of Lagundi. I've just seen a lot of in silico studies of many of the compounds seen in different plants. But there have been studies on some TCM drugs, no? Which are a lot of them are herbal. And mostly I've seen those of TCM. Even for the angiographies, parang it wasn't really based on the COVID itself. So we need more studies. I'm sure there is something out there that can help us. But one good thing that we've seen in this mild study. So even dun sa placebo group, ang dami naman talagang gagaling na basta maganda yung ating care in terms of hydration, nutrition, and all that, no? Kasi ang daming nawawala ng pag-asa na they think if they get COVID, it's already death sentence or something like that, no? Hindi no? Ang dami namang mild, moderate, and very, very few will actually become severe or critical, no? So making sure that we do appropriate supportive management that is actively doing something. No, yung lately we've had all this COVID at home. How do you treat COVID at home? That is very, very important for the supportive therapy. No, people feel have so much anxiety about getting COVID, but when in fact, ang dami natin magagawa in terms of supportive management, isolation, At ang dami-dami namang gumagaling, no? So, let's not be hopeless about this whole situation. We hope the vaccine is around the corner, coming to us. But again, ang daming research na ginawa, no? Pero ang daming hindi rin helpful, di ba? Nandiyan na tayo sa hydroxychloroquine, yan yung CPT, no? But again, like many viral diseases, supportive management is really the most important. Kahit yung dengue mo, ang measles mo, flu, no? Yun pa rin ang pinaka-importanting treatment.
Okay. Thank you, Doc. So question for Dr. Gowiran. Is there a difference in the amount of antibodies or effectiveness of the antibodies with convalescent plasma obtained from different types of infected individuals, that is from asymptomatic, mild, or severe cases?
That's a very interesting question. No? We had some references before kasi when we first started out, hindi pa routine yung pag-measure na antibody titer. So parang mag-screen muna sila and then saka namin i-test yung blood products. But later on, when we had more data, may mga studies abroad that showing that those who had asymptomatic disease or those who had only mild disease, yung amount nilang immune response is really low. So mas mababa yung antibody titer sila compared to those who have been hospitalized. Another factor that they saw was actually gender. Male patients tend to have higher antibody levels compared to females. And then another is age. They found out that those who are older are able to generate more antibodies versus the younger patients, no? But wala tayo nung strict na calculator tool naman to say to predict kung sino talaga yung magbibigay ng mas mataas na antibody levels, no? As to the response, kung how that will translate, really that's going to be challenging. Pero what we really do, we want to standardize. So we have these potential donors which we think would be good donors. But in the end, we want them to have at least the antibody titer should have at least a signal to cutoff ratio of 9.5 for it to reflect the data that the US is showing that there's some benefit to giving that high titer and convalescent plasma therapy early during the disease. So iba-iba talaga din, depende sa donor kung gaano kataas yung ma-generate nila. But so far, ang consistent talaga, pag hospitalize yung donor, mas mataas yung ibibigay niyang antibody titers compared to those who had mild disease or asymptomatic disease.
Right. Thank you, Doc. And a question for Dr. Marambo Lazarte. From the 10 halamang gamot by DOH, is Lagundi the only one subjected to molecular docking analysis against COVID-19?
One of the what do you call this, scientists in MSU contacted me that they also did some for Sambong and they found some compounds, sorry, I forgot which protein from the SARS-CoV-2 that they actually tested that also had high affinity, no? One of the targets for antiviral. So yung Sambong daw. But I haven't seen her whole paper. It's still for publication. So there are some who are testing the other halamang gamots, pero hindi pa sila napapublish.
Okay, Paul, thank you, Doc. And for Dr. Gowiran, do you think that patients who have mutations in the gene for the variable regions of antibodies would have problems in protecting against SARS-CoV-2?
I think probably that's going to be a factor in terms of how they will be responding to the SARS-CoV-2. So I can say for certain, but looking at it, think of it, mukhang yes, that would become an important factor in how they will respond.
Okay, thank you, Doc. And I think this is our last question for Dr. Maramba Lazarte. Is there a harm in or is there a potential for harm in self-medicating with Lagundi
Lagundi is an over-the-counter drug. As we've seen from the non-clinical studies, its LD50 is super, super high. To reach the LD50, you need to take 1,000 tablets. Okay? So it's super safe. Sorry, syempre, super advocate ako. Ninenervyos ako pag wala akong lagundi sa bahay kasi I have allergies, I have cough, and actually our team was also taking it when we go to the quarantine centers, no? Kasi pag meron ng may ubo, may super, oh, meron ka na, kumuha kayo dyan sa stash natin ng lagundi. And it's really very safe. And even the, what do you call this, they did some reproductive studies, although this was not published, even for pregnant animals, there was no problem in terms of mutation or whatever. It's very, very safe in terms of an herbal medicine. That's why it is an OTC drug.
Right. Okay. Thank you, Po, for that. And again, thank you to our two speakers, Dr. Maramba Lazarte and Dr. Gawiran, for all those additional learning points. And thank you very much to everyone for actively participating. And before we proceed with the next set of lecture sessions, we'll be having a break. But before we proceed, as promised, we will now be announcing the winners of the PSA MedEureka 2021 Bingo Raffle. Are you all excited? I hope you are. Let's give a warm, real or virtual round of applause to our lucky winners, Jeremy Seriales and Sheila Visera. I hope you all are clapping. I ask the winners to turn on their cameras for a picture, and congratulations. To all who participated in this raffle, we thank you all so much. To the winners, please wait for your prizes as the organizers will be contacting you. Now go. Now is our time for our break. You can move around, go to the restroom, or stretch your arms and legs. All right, we'll be back after the break and remain forever young. Well, for those who are forever young and our youngsters. All our participants, we will be starting at 2:45. All right. Welcome back, everyone. Now we'll continue with the afternoon session for today. Our last speaker will be telling us the story about the fastest vaccine ever made. He's a physician scientist with over 10 years of international experience in clinical research and development, medical, scientific and regulatory affairs, and program management of vaccine development in Asia Pacific, Europe, Latin America, and Africa. He is the first Gates Global Health Fellow from Asia at the Bill and Melinda Gates Foundation, where he was able to lead international tuberculosis programs. He is also a global medical director for TAPIDA, a TED educator, a digital health expert for the WHO, and a global assessor for the Royal Society of Tropical Medicine. Right now, he works with vaccine safety experts to the Task Force for Global Health and is part of the Safety Platform for Emergency Vaccines project. Everyone, let us all welcome Dr. Melvin Sanikas.
Thank you very much for the kind introduction, Nico. Can you hear me?
Yes, Doc, I can hear you.
Okay, so let me just share my slides. And if you can tell me whether you can see my slides, that would be great.
Yes, sir, we can see the slides.
Okay. So first of all, good afternoon, right? Yeah, good afternoon, everyone. Thank you, UP Physician Scientists Association, for the invitation to be part of your MedEureka 2021 and the discussions on COVID. Today, I'm going to talk about the story of the fastest vaccine ever made. You already know that this is a COVID vaccine, right? And you most probably know already some of the things that I will be saying here. but I will also be sharing behind the scenes stories, things that you may not have heard or read about. And my goal for this talk is to really highlight the fact that even in science, um, the saying, if there's a will, there's a way, applies. And that collaboration is key, really, to solve this this pandemic, the the the, the outbreak of this COVID that uh, basically changed our lives the past years. And I hope that we do not forget this mindset after the pandemic is over. So first of all, some disclosures. I am employed by Takeda in the vaccines business unit, and I work as a technical consultant or an advisor for several groups and companies listed here. But I am not here representing any of these organizations today, and I am here in my personal capacity as a physician and a scientist who has been working on vaccines in the field of vaccinology and virology over a decade now. So a review of the vaccine development timeline, right? The traditional vaccine development timeline. So we know that it's a long, complex, and expensive process. It takes about 10 to 15 years on average. And I'm sure you've seen this or other similar versions. We start from the exploratory stage, of course, or the discovery stage. This is where um we do basic laboratory research, and then this lasts often for from 2 to 5 years. And academic and governmental scientists identify natural or synthetic antigens that might help prevent disease. And then these antigens may include virus-like particles, weakened viruses or bacteria, weakened bacterial toxins, or other substances derived from the pathogen itself. Then we move on to the preclinical stage, where we use tissue culture, cell culture systems, or animals to assess the safety and the candidate vaccine, and the immunogenicity, or the ability to provoke an immune response. The animal subjects may include mice, rabbits, ferrets, monkeys, and the studies here give us an idea of the cellular immune response, and the cellular response in general, that might be expected in humans. In this stage, we also see whether this antigen we are trying to make into a vaccine is safe. We look for the starting dose of the next phase of research. And many candidate vaccines never move beyond this stage. They fail to produce the desired immune response, or they fail to, or we see some safety signals. And in this stage, a lot of the candidates are actually discarded. So the preclinical stage often lasts 2 years and usually involves researchers beyond academia and the government, typically small biotechs or startups. Then the developer submits an application for an investigational new drug or an IND before you start with the clinical trials. So the clinical trials, of course, we use the vaccine candidate in humans. That's why it's called clinical. We start with the phase 1 trials. This first attempt to assess the candidate vaccine in humans is also sometimes called first in men, first in humans, and it involves a small group of adults, usually 20 to 60 or 80 subjects. And the goal of phase 1 testing really are to assess the safety of the candidate vaccine and to determine the type and extent of immune response that the vaccine induces. If the candidate vaccine is promising, then it can move to the next phase. Phase 2, where we use a larger group of several hundreds of individuals. And here, some of the individuals may belong to the group that is at risk of acquiring the disease. So we try to make sure that we're using the people that we want to use in phase 3 as well. And we include a placebo group. And the goal of phase 2 really, one is to study the candidate vaccine safety, immunogenicity, And then we also look at the proposed doses, the schedule of immunization, and the method of delivery, whether it's going to be intramuscular, subcutaneous, or whatever. And then if the candidate passes phase 2, we move on to phase 3, where we give the vaccine candidate to more people, usually thousands to tens of thousands of people. And here, the subjects are randomized, and it's double blind, and it involves the experimental vaccine being tested against a placebo or a vaccine that's been approved and already used in real life. And one phase 3 goal is to assess the safety of the vaccine in a large group of people, because certain rare side effects might not surface in the smaller groups of subjects tested in phase 2. And then, of course, vaccines efficacy is tested as well. And these factors might include the following. So you want to see whether the candidate vaccine really prevents disease, whether it prevents infection with the pathogen, or does it lead to production of antibodies or other types of immune response related to the pathogen. And after a successful phase 3, the vaccine developer will submit a biological license application, or an NDA, a new drug application, to the National Regulatory Authority, or the NRA. And then the NRA will inspect the factory where the vaccine will be made, and approve the labeling of the vaccine. After its license, the NRA will continue to monitor the production of the vaccine, including inspection of the facilities and review of the manufacturer's test or lots of vaccines for potency, safety, and quality. And that's why this also takes between 1 to 2 years in the pre-pandemic era. And phase 4 studies are studies that developers may do after a vaccine is released. Some countries require local phase 4 studies, some don't. But the developers usually continue to test the vaccine for safety, efficacy, and other potential uses. For example, the quadrivalent HPV vaccine was initially approved for cervical cancer and genital warts, and then subsequently it was approved for other types of HPV-related cancers. So this is the vaccine development timeline. And I have been lucky in my career because I have experienced all these phases. Part luck and somehow a deliberate decision to really experience all these different steps. I started my career after passing the physician's licensure exam in 2006. And I worked as a medical reviewer and a clinical regulatory scientist at the Health Sciences Authority in Singapore. So it's like our FDA, right? And then I moved to join a small biopharma company where I was in charge of submitting new drugs to the different countries in Asia Pacific. And then I moved to Italy, where I did my training in vaccinology and vaccine development at the University of Siena, and on-the-job training at Novartis Vaccines, which is now GSK. Here I worked mainly on influenza and meningococcal meningitis B. Then I moved back to Singapore to join GSK, where I was mainly working on HPV, influenza, and other vaccines, considered travel vaccines like typhoid fever, meningococcal meningitis, and also HIV, but not vaccines, but instead antiviral drugs for HIV. And then I moved to Seattle to join the Bill and Melinda Gates Foundation, where I worked mainly on TB vaccines and a little on HIV vaccine development. Then I moved back to Singapore to join Sanofi Pasteur, where I work again on influenza, meningococcal meningitis, and a little on RSV. And now I'm here in Switzerland working on dengue and Zika. And of course, COVID happened, so I am now also involved in COVID. This is a table I created early on when the pandemic was just declared. And my goal really was to give people an idea of the speed of development of the different vaccines for different pathogens, considering the different scientific era these germs were discovered and the different technology available during those times. So the keyword is different, all right? We are also in a different situation now. And traditionally, it takes 10 to 15 years to develop vaccines. And if you look at this table, for example, the the pathogen that took the longest time for a vaccine to be available is the malaria parasite. We have a malaria vaccine, and just a couple of days ago, another malaria vaccine candidate published their results and showed that they have efficacy of 77%, which is very good because the WHO target is 75%. And the fastest vaccine before COVID was the mumps vaccine. And we know that we don't have a SARS-1 vaccine because the virus disappeared. MERS coronavirus, we will have a vaccine soon. And SARS-CoV-2, it took 10 or 11 months. So so what the public knows, right, about vaccine development and why this became really the fastest vaccine ever made. So if you look at this, you will see that on top we have the traditional vaccine development, and below we have the SARS-CoV-2 vaccine development. And for COVID, we save a lot of time in the discovery and non-clinical stages because SARS-CoV-2 is not the first coronavirus. It's the 7th coronavirus if you count the 4 non-outbreak coronaviruses plus SARS plus MERS and SARS-CoV-2. Scientists have been studying coronaviruses for over half a century now, and because of that, we know the structure, we know the genome and life cycle of coronaviruses. And also because of SARS in 2002, 2003, and MERS in 2012, there were already lots of groups working on these coronaviruses even before COVID came into the picture. Then with clinical studies, we know that this is the typical clinical trial setup. You have the phase 1, phase 2, phase 3. But for COVID, what happened was that these studies were done in parallel. So instead of doing the typical clinical trial scenario where you do phase 1, you wait for the results, you publish, you apply for funding for phase 2, you do phase 2, wait for the results, publish phase 2, and then apply for funding and then do phase 3. So these things take years. And for those of you who have experience applying for funding, you would know that this takes a long time, and also publishing also takes a long time, and that's made those are the reasons why these phase 1, 2, 3 clinical trials in the past took a long time. And again, for COVID, these studies were done in parallel. So some studies, phase 1 and 2, were done in parallel. Some developers did phase 2 and 3 in parallel. And then vaccines were also produced at risk. So even before we knew that they would work, developers already started developing them in bulk. And of course, there's a risk here, right? Because what if after you finish phase 3 or even just the interim analysis, you see that the vaccine candidate does not work? So it actually will mean that all of the vaccine doses that you produced will just go to waste, right? But luckily, this did not happen. And also the fact that most of the developers thought of the spike protein as the antigen to target. Also, we were also lucky there because we knew that the spike protein is, of course, the most important antigen for SARS-CoV-2 to infect us. But then it could have gone the other way, right? It could have been a different scenario. And also, we learned a lot of lessons from other pathogens as well. In RSV development, we knew that it matters if you use a different type of configuration of the protein. So, for example, in a few years ago in RSV vaccine development, they use a post-conformation shape of the protein that's used by the RSV, and that was not successful. And they found out that if you use a pre-conformation version, it would produce a better immunogenicity. And this was applied here, especially for the Moderna vaccine, for example. And Of course, in terms of filing, it was also different because traditionally you wait for all these data from the non-clinical and all the clinical trials, and you create a dossier and you submit it to the regulatory authority. But with COVID, what happened was that developers were submitting data as and when they arrive. So behind the scenes, global collaboration was really key for this to happen. Chinese researchers quickly sequenced the virus and shared their data with other scientists early in January 2020. And once the genomic sequence was out, um, the developers started creating vaccine candidates. And of course, the other thing that happened was that many scientists who were working on other pathogens stopped what they were doing and focused on COVID. And there has never been a single time in human history where thousands of physicians and scientists worldwide worked on and are still working on a single disease. And this has never happened even with HIV/AIDS. We also had CEPI. CEPI is the Coalition for Epidemic Preparedness Innovation. It is an innovative global partnership between public, private, philanthropic, and civil society. And this was launched in 2017 in Davos, in Switzerland. And many of the vaccines we have now and others in development have received financial support and technical support from CEPI. Funding is, of course, a major bottleneck for research, not just for COVID, but for research in general. And as I've mentioned, vaccine development is expensive, and the cost of developing a vaccine from discovery to approval is estimated to be between 200 to 500 million per vaccine, and that's a lot of money. But because we are in a pandemic, the US, the UK, EU, and other developed countries with funding agencies like the Bill and Melinda Gates Foundation, Wellcome Trust, pledge a lot of money to fund research. The US government Operation Warp Speed spent over 10 billion US dollars, and celebrities like Dolly Parton even donated $1 million to coronavirus vaccine research. In March and April last year, several other celebrities who wanted to remain anonymous contacted me, and I put them in contact with vaccine researchers, and they gave their money to the Moderna vaccine research and some other vaccine research researchers happening here in Europe. And in a non-pandemic situation, developers need to apply for funding to start new studies or continue existing ones. And for COVID, this was not the case at all, because over 25 billion US dollars went out to fund vaccine research. And then we have advances in non-clinical research. So non-human primates are used in medical research because of their similarities to human beings, and results from research on non-human primates can often be applied to humans. And scientists have learned much about diseases, prevention, and treatment for both humans and animals. And 7 years ago, I was working for Mr. Gates, and I was asked to create a collaboration to help advance vaccine research for tuberculosis. So we created and launched the collaboration for TB vaccine discovery, or CTVD. This included over 70 institutions and pharma companies, and now over 90, I think, or almost 100. And one of the working groups there was the testing of the vaccine candidates in rhesus or cynomolgus macaques before human trials. And some of the same groups we had in the CTVD are the same developers of the vaccines we have now for COVID. And just a side story, I actually invited Tony Fauci to attend this meeting in 2015. He was not able to come, but he sent someone from the NIAID to join the meeting. But he called me and then apologized that he couldn't come. So for me, it just shows character, right? Because he is the head of NIAID, and he could have just told me that he couldn't come. But instead, he sent an email and he set up a call so that he can apologize that he couldn't come, and that he really wanted to support this project. So that's a side note. This is the publication we had in 2016. It's basically talking about advances in vaccination against TB with wholesale mycobacterial vaccines. But here we also talk about talk a lot about the importance of non-clinical research. And the picture here on the upper right is from the non-human primate lab that we help support in the Netherlands. And a lot of the vaccine candidates for COVID at the moment, they're using this specific lab to advance their research from non-clinical to clinical. And last but not the least, of course, the vaccine platforms that enabled the first COVID-19 vaccines to reach the finish line use the mRNA technology, as we know. And this is Dr. Kathleen Carico. She started studying mRNA in the 1990s, 1992, 1993, actually. And of course, during that time, she was not taken seriously by the scientific community because they thought that her idea would not work. So now she is a senior vice president at BioNTech. And so while the COVID mRNA vaccine is new, we know that the technology is not new. And the same goes for viral vector vaccines like the ones being used, like the AstraZeneca Oxford vaccine, because we know that there are other vaccines that are viral vector that we are already using, like the vaccine for Ebola. So COVID has exposed weaknesses in many things, right? Especially in the infectious disease surveillance and response capabilities, and frankly, weaknesses that have persisted in spite of obvious harm. And I will not be able to talk about all these things, but I will focus on what I think we should focus on in terms of science. So I think we should really put our money where our mouth is. COVID will not be the last pandemic. The economic disruption caused by the COVID-19 pandemic could costs between 9 trillion and 30 trillion and counting, because we are still in a pandemic, right? And if we use just a fraction of this amount of money to prepare for the future, we would be in a better shape to face the next pandemic coming. So, okay, let's assume that we have a sustainable model of funding now, and there's still the critical question of ensuring that the research that is funded meets both the short-term needs and the long-term needs of the scientific community. So we should also revisit the things we fund. This is a nice cartoon that I saw last year by an Indian cartoonist, Satish Acharya. And this is just showing us that in most countries, maybe not in our country, but in most developed countries, this is what's happening. The budget for defense is huge and the budget for healthcare and science is just so small. But then when the pandemic happened, people were expecting the doctors and scientists to save the world with just the budget that is even less than 10% of what they're giving to the military. And then, so this is a slide that I took from one of Tony Fauci's presentation in 2017. This is just showing us all the potential, the emerging and re-emerging infectious diseases. And of course, COVID is not yet here, but it just shows us that there are so many pathogens out there that could become the next pandemic. So we have to be ready. And speaking of vaccines and vaccination, one of our neighbors, Indonesia, has already administered over 18 million doses of the COVID vaccine, and they give around 200,000 each day. And they've already vaccinated 5 to 6% of the population of the country. And the reason for this is that they have this biopharma. Biopharma is a government-owned vaccine manufacturing vaccine manufacturer in Indonesia, and they worked with Sinovac to produce vaccines locally in Indonesia, and that's the reason why they seem to be doing okay in terms of the vaccine doses and vaccination. And this is a map of the developing countries' vaccine manufacturers network. So there are 41 manufacturers in 14 countries that are considered low and middle income. And if you notice, you look at the map, one country stands out because that country does not have a local vaccine manufacturer, and that's our country. And in the list of the top 10 ASEAN countries, according to GDP, all of the countries in the top 6 have local vaccine capacity except one. And so it's not really about the money, right? Because there are countries that are that have less money and lower GDP than our country, but they have vaccine manufacturers. I mean, Vietnam has 4 local vaccine manufacturers in their country. And these are my last remaining slides, and I just want to talk about the vaccine for HPV, or the human papillomavirus causing genital warts and cervical cancer. The vaccine works extremely well, and in 10 years after the vaccine was recommended in 2006, the number of HPV-related infections and cancers have dramatically been reduced, and some countries are on the track to eliminate HPV, like Australia, for example. But did you know that one of the scientists that helped develop Gardasil is actually a Filipino? I had the pleasure of working with Danilo Casimiro several years ago in Seattle. And I just wanted to mention this as a reminder to all of us that we don't lack the brains or the talents to do these things. And I think I am preaching to the choir here, but we need support, not the kind of support that changes depending on the political party or the current administration. We need to have support whoever is the president, or whichever political party is in power. And I think at the moment that's something that we don't have much. So I want to end on a positive note. So this is data from Israel, a country that has vaccinated 59, almost 60% of its population. And you will see here that even though the country has already opened, and even though they had their one of their major Jewish celebrations 3 weeks ago, you see that the cases are going down in all age groups, even in people who were not vaccinated. It just shows us that if we vaccinate enough in our population, we will see cases, hospitalizations, and deaths go down as well. So thank you for your attention, and I'm happy to answer questions.
Thank you very much, Dr. Sinikas, for that insightful presentation. And truly, with all the focus now on vaccines, it's very important for the general public to know that vaccines take time, and in that way, they can marvel at actually at what's been accomplished over the past year and a half, and that vaccine manufacturing production just doesn't happen by magic. And at this point, we'll again have a 20-minute open forum for the clinical management talk of Dr. Salinas. You may enter your questions through Slido. Go to slido.com and enter the code shown on your screens and in the Zoom chat. Again, if you'd like to speak, please use the raise hand function in Zoom and wait to be acknowledged before unmuting yourself. Kindly introduce yourself before giving your question. If possible, please turn your cameras on when speaking. Okay, we have a question again from Dr. Kawili. Sir.
Thank you very much. And many thanks to Dr. Sanikas for driving home the point that we really need local vaccine manufacturing capability. And some of you already know this, but Lady Med has an identical twin right beside Festival Mall. And it's in front of what used to be called the Biological Production Service. So in 1924, this was set up, and we had capacity until sometime in the 1990s to produce at least some kind of vaccine, after which it was completely defunded. So I'd just like to ask Dr. Sanikas his opinion. So what do you think is like the way forward to, regain this lost capacity, to pick up where we left off? Because I think it was mainly a government-funded operation back then. Although we've been told time and again, like in the interest of economies of scale and the International Division of Labor, so on and so forth, that it's more cost-effective to just outsource everything, or at least leave it up to the private sector entirely. Could you, at least in outline form, share with us your thoughts on how we could actually operationalize this renaissance in local vaccine manufacturing, so to speak? Thank you.
Yeah, thank you for that, sir. That's a very important question. I think there are several ways we can approach this. So other countries, they've so Brazil, for example. So maybe it's a wrong example because it's a bigger country than us, but other countries have asked vaccine manufacturers to do a tech transfer. This is one thing. So Indonesia started with this. They had a partnership with several Japanese laboratories and companies, and this started the biopharma manufacturing manufacturer in Indonesia started with a tech transfer from a Japanese company. I think it was Kaketsuken, and from there they just built on with the funds from the government and funds from other philanthropic organizations in Indonesia, and we can follow that route, I would say. And the other thing is, for Brazil, what they did was that 10 years ago or 15 years ago, they had an agreement with GSK, where they will only be using vaccines produced locally. So GSK did a tech transfer, and during that time, they were sharing the profits, of course, and it was good for the company and it was good for the country as well, because they were getting money from the vaccines that they were selling, like the pneumococcal vaccine, and they were using it to fund their own research and to basically develop their institute. And the other way I could think of is do partnerships with countries in the region that already have vaccine manufacturing capacity, like Vietnam, Indonesia, Malaysia, Singapore, and it doesn't have to be a full-scale vaccine manufacturing capacity only in the Philippines. It can be parts of that. It can be, maybe we can start with uh, the end processes, like filling of the doses, and from there we can build on. I don't think we can start from scratch to the end of vaccine manufacturing without requiring billions and billions of money. We can start small, and then I think we can use this pandemic as a as just to really push our governments to see the benefit in the value of having local vaccine manufacturing capacity. And I'm sure everyone, whichever side of the political spectrum you are, I think everyone agrees that having a local vaccine manufacturer will really help us, not just for the future pandemic, but for other vaccines that can be produced relatively easily. And it will also help us earn money, right? Because we're producing for ourselves and we're buying vaccines for ourselves. So these are some of the thoughts that came into mind, and I think we can do this if we have the support of the people and the government.
Thank you. Just one quick follow through. So it's occurred to me that probably in the greater scheme of things, the volume of vaccine production utilization might even be larger for non-human animals because of agriculture
Yes.
and other things. And I mean, how much coordination is really going on between the community of human vaccine manufacturers and researchers and their veterinary counterparts? And what's your take on that? Should we have some kind of closer coordination with them? Should we have a unified approach? I mean, considering that, as a case in point, SARS-CoV-2 or I mean, COVID-19 itself appears to be zoonotic.
Yes.
Thank
Yes,
you.
sir. So in countries like Nigeria and Morocco, they actually started with a vet vaccine facility before it evolved into a like a human vaccine facility. So it is possible, and I think we should do that, especially with think about the One Health concept, right? Because we know that our health is affecting the health of animals and the environment as well. And I think it is high time for us to think like this, because if we want to be ready for the future pandemics, we need to work together, not in silos.
Thank you so much.
Just to add, sir, actually in Russia and other countries around Russia, the stans,
Yes.
Kyrgyzstan, in all these countries, um, the the institutes that are doing their COVID vaccines now are
Yeah.
veterinary research institutes.
I see. Is that like a feature of the Soviet system that was inherited by these countries?
Partly, yes. Yeah,
Okay.
yeah,
Okay.
partly, yes.
Okay. Thank you.
Thank you, Dr. Kawili, for your question, and to our speaker for his elaborative response. Now we can go to some of the questions from Slido. The first being, how should we respond to lay people who are saying the vaccine development process was fast-tracked and that they do not believe its effectivity and safety? I suppose that this refers to the vaccine for SARS-CoV-2.
Yes, thank you for that question. And of course, we don't have time to tell them all these things that I told you today, right? So I typically just tell people that vaccine development in the past took a long time because of bureaucracy, lack of funding, and no sense of urgency. And if you have funding, if you do something with bureaucracy, and if there's sense of urgency, we can do things much, much faster. And this is what we've seen here. And I always tell people that in terms of safety, we did not compromise that. What was put at risk as is financial, actually, because as I've mentioned, we produce all these doses in advance without even knowing whether they work or not, right? So it was a financial risk, not a safety risk. Although I also tell people, to be honest, that we don't know whether these vaccines will be effective for a long time. So this is what we don't know. We are still following this up. We know that the vaccines are working 6, 7, 8 months after receiving them, after getting the second dose. But beyond that, we don't know. And every time I tell people this, and you are honest about what we know and what we don't know, people are usually okay with it, because if you tell them no, vaccines work, vaccines are safe, and there's no issue, and that's the thing where they doubt what you say. But if you tell them straight to their faces what are the facts and what are the things we don't know, most of the time people are logical, and they understand what you're saying.
I see. And in relation to that, there's another question. Can we expect, therefore, vaccine development for other pathogens to speed up as a result of lessons from this pandemic?
In a way, I think yes, but if it's a pathogen that's not as um, how do I say important as COVID, maybe not, right? Because really the main reason why we had all these support, financial and otherwise, from all the players is because we are all affected. So if you look at what happened during SARS and MERS, because only several countries were affected and not the whole world, right? There was no global sense of urgency. And I would say for a disease that affects almost everyone in the world, it will be different. And sad to say, if the disease only affects the poor countries, you won't have the support. This is reality.
I see. Thank you for that. Another question. Why is it that Vietnam can create their own vaccine while the Philippines cannot? What is your opinion regarding this?
So Vietnam, for those who are not familiar with the Vietnamese culture, they are very persistent, the Vietnamese people. And they had this Chinese communist thinking in the past, although they are now in a love-hate relationship, they still have that thinking. And if you notice, countries like China and Vietnam, these are countries where the governments are very powerful. You have people who complain, of course, everywhere, right? But then at the end of the day, they will still follow what the government says. And this is a different way of thinking. And also, they had a lot of support from the CDC, and the ECDC. They had lots of collaboration, and many of their vaccine manufacturers started from those small collaborations. So again, maybe for us um, to be able to move forwards in this direction, we need to have more collaboration with other countries or companies that can help us develop.
Thank you. On the next question, what can be done to educate people about the importance of taking the SARS-CoV-2 vaccine, regardless of its brand?
Yeah, I get this question all the time, and it's not easy to answer because, you have all these different vaccines being talked about on the news and in social media, and of course we want the best, right? Who doesn't want the best? If we buy iPhones or our laptops, we always want the best, right? And we're always saying we're willing to pay for the best. But the reality is we don't have the doses. If Pfizer can only create 15 million doses, I think we should all have Pfizer. I agree with that. But the fact is they cannot do that. Moderna cannot do that. And all the companies that now have vaccines that have been approved in some way or form, we now have 11 vaccines approved by at least one national regulatory authority, and none of these companies can create more than 2 billion doses a year. So really what we have to tell people is that we can wait if we want, but then it means that the pandemic will be much, much longer. Are we willing to wait for 7 years, for example? So, and then usually when I tell people that, they would think, oh, 7 years of lockdown. No, I'll get it now.
Yeah. All right. Thank you, Doc. And maybe it's worth encouraging people to not be so brand conscious in that sense. Right. The next question, what is your advice to a medical student who plans to pursue a career in vaccine development or vaccinology in the future?
Very good question. So to be honest, I was not really a good student in pharmacology when I was in med school. Out of the 4 exams, I actually failed 2, and and I took the finals to pass. So it just shows you that you don't have to be the best student now to have the opportunities in the future. Um, there are several ways to approach vaccinology. I know people who started as pediatricians. This is one route. There are other people who are IM specialists. This is another route. I personally know several colleagues here in Europe who are anesthesiologists, because anesthesiologists are very good with drugs and pharmacology, and for me it's different because I'm not an anesthesiologist, pediatrician, or IM specialist. I did my training in vaccinology in Italy, and there are several training programs. So there's one in Italy where I did it. There's another one that's called Live. It's sponsored by Erasmus. It's a European consortium where you study in France, Belgium, and Spain. And I know a few UPCM graduates who finished this as well. There are a few courses in the US, but of course, I'm pro Europe because I'm here, and I always tell people that you mentioned about when you talk about vaccinology, you talk about Pasteur, Robert Koch, and all these people, and these are all Europeans, and that's why I'm here.
I see. Thank you for that, Doc. And there's another question. What do you think is the effect of the mutations on the spike protein of SARS-CoV-2 in vaccine efficacy?
Okay, very good question as well. So the short answer, we don't have enough time for this, but the short answer is that when the body produces antibodies against a spike protein, this is not just one antibody. There are many antibodies that produces little antibodies against the spike protein, right? So when you have mutations on a specific portion of that spike protein, maybe the furin site or whatever site, this is just a small portion of this protein. And you still have other antibodies that can target the rest of the spike protein. So that's why we are seeing a decrease in efficacy, for example, in the trials of Novavax and J&J in South Africa, but you see that there is still efficacy because some antibodies can target that. And this is just one part, right? Antibodies. We don't talk about T cell immunity. We know that for SARS and MERS, people who have been infected with SARS and MERS 10 years ago, if you look at if you check their blood, they can still do some, they can still fight SARS-CoV-2. So there's some effect there as well. So it's B cells and T cells. And for sure, the vaccines that we have at the moment, they can still work. They will still work. But if you ask me in 12 months, maybe I would say something different. If we allow the virus to mutate and mutate further.
Yes. Uh, Thank you. And I think we're down to our last question for this afternoon for Dr. Sanikas. Why are there cases of individuals who still reportedly got COVID-19 after being vaccinated?
Um, Another important question. So firstly, we know that it's not instantaneous, right? When you inject someone with the vaccine, you're not protected yet. You need at least 2 weeks to see some antibodies. And for vaccines that need 2 doses, you need at least 2 weeks after the second dose to have the optimal protection. And of course, we also know that some people, they might not show symptoms, but they could have been infected already just before getting the vaccine. So all these different time points before vaccination and before the second dose, you can be infected in any of these time points. That's why it's really possible for people to be infected even after they're vaccinated. And also, there's a small portion of the population that will not produce antibodies. We know this from hepatitis B, for example, that there is just maybe 2 or 3% of the population who never produce antibodies, even if you give them 2 doses. But if you challenge them again with a third dose, a third booster, or a fourth, then you can see antibodies. And this is happening in some of the countries in the Middle East that used Sinopharm or Sinovac vaccines, that for those people who did not produce antibodies, they get another booster.
All right. Okay. Thank you very much, Dr. Sanikas, for that and for the high yield discussion. And thank you to all our participants who sent in their questions. Now, we'd like to introduce somebody who would synthesize the previous lectures for this afternoon. And to do that, I'm sorry, here. To synthesize what's been discussed this afternoon, one of our members is here to provide his insights regarding the basic science, clinical research, and clinical management of COVID-19. He's a graduate of BS Chemistry in UP Diliman and a registered chemist, and also an MD PhD in molecular medicine student. He is a researcher in the Biological Models Laboratory in UP Manila and an incoming visiting researcher in the Center for Genetic Medicine Research, Children's National Medical Center in Washington, D.C. He was also the president of UPPSA the previous year. And that, let's all welcome Mr. Rafael Vincent Manalo.
Thank you, Nico. Hello and good afternoon, everyone. First, I would like to thank you all for being with PSA this far. I would also like to thank our speakers in the morning session and in this afternoon session, Dr. Cecil, Dr. Dion, and Dr. Melvin, for sharing with us your expertise. We have had a lot of information to crunch in a day and a lot to take in, and it can be overwhelming to analyze all these things that COVID has revealed to us. And so I encourage you to stay with me for another 10 minutes as I try to package all of this in my summary. So allow me to include the morning session. Earlier in the morning, we discussed about health systems approach to COVID-19, how we should treat it not as a simple case of civil disobedience, but as a crisis and as a disaster that requires disaster management and risk reduction, and how various institutions in the healthcare systems, from your healthcare institutions to benchwork in the lab to institutions committed to health informatics should work together to get good non-erroneous data as basis for good policies implemented in record time. This afternoon, we are graced with eminent speakers who have just shared with us the various potential treatments for COVID. such as your Vitex Negundo or Lagundi and convalescent plasma therapy, as shared with us today by Dr. Cecil and Dr. Dion, and an inspiring pipeline for vaccine development, as shared with us by Dr. Melvin, which we might actually have to adopt eventually as we establish our own virology and vaccinology institutes in the Philippines. So first off, Dr. Cecil shared with us the ongoing clinical trial on the use of Lagundi for COVID-19. It is noteworthy that Dr. Cecil's mother, Dr. Nelia Maramba, the mother of Philippine herbal medicine, and their colleagues from the IHM, the Institute of Herbal Med in UP Manila, were the ones who actually spearheaded the use of Vitex Negundo or Lagundi as an herbal medicine for cough. And please correct me if I'm wrong, in collaboration with Pascual Lab, had it patented and commercialized as Ascof Lagundi, which we now see in multiple drugstores nationwide. Now we have a trial for COVID being done under Dr. Cecil, and it can be seen from the preliminary results of the trial that it is actually still safe, with a big potential to emerge as an efficacious supportive treatment for mild COVID in terms of their clinical outcomes, such as progression to disease, your clinical recovery, the resolution of the influenza-like illness, and other criteria. And I'd like to emphasize that reverse pharmacology is actually a very interesting concept because it tries to validate the traditional practices of Filipinos. So people go to healers for many complaints, some of them get healed, and then there comes the scientific inquiry on the role of the herbs and roots that they use. So using this approach, Lagundi as an herbal medicine was born, which we use to this day. So this trial now for COVID-19, based on its efficacy for cough and the ducking studies suggesting its antiviral potential, just shows us that the safety profile and the efficacy of Lagundi for one symptom or disease does not necessarily make it safe and effective for another. We can actually apply this knowledge to some anti-COVID drugs being touted out there. One which is effective now for COVID suggested as which is actually a safe and effective antiparasitic, but is actually toxic at pharmacologic doses suggested for COVID-19 prevention in humans. To add to that, plants also have varieties, and a variety found here in the Philippines will differ from a variety found in another country. And even between regions in the Philippines, you would have different weathers, different soil qualities, different cultivation protocols, and different extraction procedures. And because of these significantly differing practices between regions, you would also have different cultivars. So, in addition to that, you also have different formulations with different excipients and different bioavailabilities. So, it is therefore very important that we have a study of our very own so that the results that we gather for its use in COVID is simply what it can offer realistically using our own variety cultivated in a specific manner and prepared in a specific way. So I know that this trial is in good hands, and we are actually excited to see its finality coming to play. Dr. Dion then goes on to tell us about the mechanisms, the risks and benefits of the compassionate use of convalescent plasma therapy for COVID. And here we learned about the passive immunity transfused patients gain from recovered donors to improve their COVID symptoms. We learned that not everyone who recovered can donate, as there is a limit of around 14 to 28 days of as an asymptomatic state for those who are eligible to donate under an established classification. And then once they are eligible, there should still be acceptable clinical parameters for their CBC and serologic tests. Recent evidence from several clinical trials actually show conflicting data regarding their benefit for COVID-19 patients, which actually led to the living recommendations of the PSMID to not recommend convalescent plasma therapy for COVID, regardless of severity. For me, this is unfortunate because now we have one less treatment for COVID to treat severe symptoms. And I believe that this conflicting data is due to heterogeneity of data. It can be due to the presence of variants we still do not know. It can be due to the method of collection, just as what Dr. Dion mentioned a while ago, or a difference in response based on ethnicity, or even to the phase of illness where you gave the plasma. But it is notable because the recommendations respond to new data as they are published, which is actually very good. If we can just obtain our own data for efficacy of plasma therapy for COVID, as in the co-clarity trial for moderate, severe, and critical patients being done in the PGH, I think it would be a better and more tailor-fit basis for the future recommendations for Filipino COVID patients. And lastly, we heard about the inspiring pipeline of COVID-19 vaccine development shared with us just recently by Dr. Melvin. And this story showcased how, in record time, the world, through its state of the art labs and pharmaceutical technologies, have produced COVID 19 vaccines with exceptional efficacies reaching 90% and above, with notable safety profiles, despite some, uh, despite, oh, I'm sorry, is my audio soft for everyone?
It's better now. It's okay.
It's better now.
Better.
Okay, sorry. So lastly, we heard about the pipeline, as I was mentioning, of the COVID vaccine shared to us by Dr. Melvin. And this story showcased to us how, in record time, the world, through its state-of-the-art labs and pharmaceutical technologies, produced a set of COVID vaccines with exceptional efficacies reaching 90% and above, and notable safety profiles, nga, despite some approaches being novel, such as your mRNA and adenoviral vector vaccines. So usually it takes around a decade to 15 years to and about $1 million or more to produce a single vaccine that is safe and effective. From the seminar of Dr. Melvin, it was around 8 years for MERS to around 118 years for malaria, with ongoing trials to this day. But it was actually the worldwide collaboration of our scientists, our researchers, and our healthcare workers that have expedited this process to less than a year, around 10 months in record time. So, as Dr. Melvin said a while ago, around December to January of 2020, the SARS-CoV-2 virus was already detected and its sequence released. And by the first quarter of 2020, the pandemic was officially declared. And then by around November to December, the trials on safety and efficacy were almost finished. And by early of this year, 2021, the vaccine rollouts were already being done in the millions. Although there have been unusual side effects reported that have delayed the recent rollouts throughout the world, I'd like to emphasize that the COVID 19 vaccines remain remarkably safe and efficacious for the time taken to actually conceptualize them, produce them, and then test them in the trials, and then after passing the trials, to mass produce them for public and private use. This gave us actually a new pipeline in vaccine production, such as doing your phase 1 and phase 2, while starting your phase 3 in parallel. And this is actually very important for future pandemic responses. It may not be applicable to all future vaccines, but for future emergencies that would require this space for production, it will be good, and it should be an established pipeline for us to have timely prevention of mortality and morbidity. So the take-home message for this afternoon is that science is evolving, and that knowledge today may be a thing of the past tomorrow. So we must actually always strive to do research and to update our policies based on the new evidence that we have. Medicine is dynamic. We shouldn't just read and memorize the books, but we must also inquire, ask, and investigate so that we can keep up with the emerging needs of healthcare. That is all. Thank you.
Yes. Thank you very much, Rafael, for providing a synthesis of the basic sciences and clinical management topics, which is concluded. Now we move on to the nearing the end of our program. To honor our speakers today, the Physician Scientists Association is uh, conferring upon our speakers certificates of appreciation. We request our speakers to turn on their videos. Now, the certificate reads, that the certificate of appreciation is given to uh, the speaker for sharing his or her invaluable knowledge and expertise as a resource speaker during the MedEureka Coursing Through the Pandemic series, given the 24th of April 2021 via Zoom. And we award the certificate to Dr. Cecilia Maramba Lazarte, Dr. Dion Tadeos Gawiran, and Dr. Melvin Sancas. And a certificate of appreciation for being our reactor is also given to Mr. Rafael Vincent Manalo. Once again, I join everyone in thanking all of our guest speakers this afternoon with a virtual or physical round of applause. And also, I'll be asking everyone to please answer the feedback form for this event. The details are going to be sent to you in the Zoom chat. And now, to conclude our event, may we welcome Dr. Paul Medina, one of the UP-PSA advisors and faculty of the Department of Biochemistry and Molecular Biology in the UP College of Medicine, for his closing remarks.
Okay, hello, good afternoon, everyone who are in this MedEureka session. First of all, I would like to thank the organizers of this MedEureka. We all know that we are currently in a pandemic. Everyone is trying to do everything to try to resolve and manage this pandemic. However, we are also busy with so many other things. Thus, we appreciate events like this where people who are in the front line of trying to manage and find solutions to the problems are given a chance to tell us what really is going on, because we do not have an idea ourselves. And thus, we really would like to extend our gratitude to those who have spent their or allotted some time in their Saturday um, moment to talk about what they are doing and share with us what they have learned so far. We also take the people who have attended, because this event was really meant for you guys. We hope that what you have learned here, that whatever you have gained, the question is, so what will you do now with the knowledge that you've gained from the speakers? Is it something that you just get and then move on with your lives? Or it's something that you really think about and hopefully would have some kind of impact to you, whether in the near future or some remote future, but something that you will keep in mind what has been shared to you by our experts, and in the future, not just be consumers of this knowledge, but also be producers of knowledge that will also help in the resolution of this pandemic. So with that, I really would challenge everybody, from the organizers to the speakers to our listeners, to keep on with the fight against COVID. And at the same time, the best way of doing that as well is keeping safe ourselves, practicing our usual way of getting ourselves infected through social distancing and through wise use of proper use of PPEs, and always be conscious about disinfecting whenever we can. So with that said, I would like to end this particular MedEureka session. Again, thank you for your attendance. Keep safe and God bless you all.
Thank you very much for your very kind words, Dr. Paul Medina. And thank you again, everyone, for attending MedEureka. Again, I'm Nico Barzaga, and it's been a pleasure to be your host, and moderator for this afternoon. And to commemorate this occasion, may I ask everyone to turn on their cameras for the picture taking. Just please hold your smile as there are several pages in Zoom.
Okay. Good afternoon, everyone. Could you please switch on all your cameras for the picture taking? Okay. Okay. So just hold your smiles as we take this picture. Okay. 1, 2, 3, smile. Okay. Let me check for more smiles. Carmela, could you check for other smiles because I can move the other panel. Sorry. I could see 25 pictures. Okay, one more. 1, 2, 3. Okay. Thank you very much for attending.
All right, that's it, everyone. Thank you very much. You may now log out. Have a good afternoon and a fruitful weekend.
That's
How much